call the meeting to order. We're going to try today to run this meeting between 2 o'clock and 4 o'clock. So I will try to do some time limits on discussions to facilitate that if possible. Agenda item number 1 is approval of minutes. Included in your packets are copies of the minutes from the July meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval. Second? Any discussion? All in favor? Aye. Any opposed? The minutes are approved. Commissioners, you've received the written updates from the Senate. Do you have any questions on the written updates? And then Ben, do you or any other Senate directors have any additional updates? Linda, and then David. At the March Commission meeting, the home health agency chapter of the state health plan At the March Commission meeting, the Home Health Agency chapter of the State Health Plan was adopted and it became effective in April of this year. That chapter focuses on a new approach based on the determination by the Commission that consumers need a choice of high-quality home health agency providers. In accordance with these regulations, staff has posted for comment draft quality measures and performance requirements to be used in Certificate of Need reviews. A public notice has been posted for review and comment. In addition, a background paper was also posted to provide details and documentation. Comments on the public notice are due by September 22nd. Staff will review these comments and present findings and recommendations to you at the upcoming meeting.
Good afternoon, Mr. Chairman, members of the Commission. Just a couple of brief updates. In your meeting materials today, staff has included an electronic data interchange information brief, as well as a report on HIE, Health Information Exchange, definition change. We encourage you to take a look at it. The report itself on HIE talks about the work of stakeholders over the last 18 months to craft a definition which exists today in statute, there's some interest amongst the stakeholders to try to propose a legislative change to broaden the definition to cover other HIE services in the state. So I just want to make you aware of the two documents that you have, and if there aren't any questions, that concludes my addition to the update.
Let's move to agenda item number 3, which is the Certificate of Need from Sheppard Pratt at Elkridge. Sheppard Pratt Health System has applied for a CON to replace and relocate its 78-bed inpatient psychiatric hospital from Ellicott City to Elkridge. Kevin McDonald will present the staff recommendation.
Thank you and good afternoon. This project proposed by Sheppard Pratt is an 85-bed psychiatric hospital. It would be a new facility built to replace their 78-bed inpatient psychiatric facility in Ellicott City. The new facility would be about 4 miles away in Elkridge. The immediate driver of the project is the fact that their lease expires. It's a facility that they lease, and the owner wants to redevelop that property. However, this is a 47-year-old facility that the applicant states is functionally obsolete and inefficient, and probably at the end of its useful life for that purpose in any case. The estimated cost of the new project would be $96.5 million. The financing would be about $15 million in cash, $7.5 million in philanthropy, about $67 million in debt, and $7.5 million in state grant funding via a requested capital appropriation from the governor's capital budget. The need analysis that was done, Sheppard Pratt is basically a statewide facility, although there is a primary and secondary service area where most of their volume comes from. They did their needs analysis based on their historical use rates and market share. MHCC staff simultaneously did an independent look at need, focused more on the primary and secondary service areas. The two analyses were very similar in terms of the need projection. However, the MHCC staff analysis, while it confirmed Sheppard Pratt's analysis of the need for adolescent and adult beds, did not find the need for a new program focused on geriatric inpatient psych. Essentially, because there are 5 hospitals in that same service area that are currently filling that need, and the demand has been growing very slowly in that service line. Consequently, staff called a project status conference and told Sheppard Pratt that we would not be able to recommend approval of a 100-bed facility based on our need projections. Although staff's recommendation differed from the Sheppard Pratt analysis primarily in the need for geriatric psych beds, at the status conference, there was no direction given to Sheppard Pratt that reduction in beds should happen in the psychiatric program, the geriatric psychiatric program. But essentially, that is the decision they made, and reduced the facility by 15 beds, which was 1 floor of the facility. That reduced the project by about 16,000 square feet and reduced the cost by about $6 million. Looking at other aspects of our criteria, in terms of viability and financial feasibility, it's been demonstrated that Sheppard Pratt can obtain the resources necessary to implement the project. There is a projection of positive operating margins, even if HSCRC does not grant a rate request related to a rate increase related to this project. Both MHCC staff and HSCRC judged the assumptions that the projections were based on to be quite reasonable. One of the benefits of this project is it is going to significantly increase outpatient availability. In terms of impact on other providers, there is a very diffused effect through many providers throughout the state. No one facility would be taking much impact at all. And I think support for the project was quite strong. Letters of support from all of the hospitals in Anne Arundel and Howard counties expressing the need for this facility. So in summary, based on staff review of the application, Commission staff recommends that the Commission find that the proposed capital project complies with the applicable health plan standards, is needed, is a cost-effective approach to meeting the applicant's need to modernize the facility, is viable, and will have a positive impact on the healthcare delivery system without adversely affecting other providers. The applicant has a good track record in complying with the terms and conditions of previous CONs. Therefore, staff recommends that the Commission approve this project. There are several representatives from Sheppard Pratt here. Perhaps after you make your motion, I'll introduce them.
I have a motion? Okay, second? All right. And make your introduction.
Harsh Trivedi, the President and CEO. Gerald Knoll, the CFO. Bonnie Katz, Vice President for Business Development and Support Operations. Scott Thomas from the Canon Design Group. And their counsel, Ella Aiken and Tom Dane.
Welcome. Any questions, comments, or discussion? All in favor? Aye. Any opposed? Do you have your CON?
Chairman, Dr. Trevelyan would like to say a few words with you.
Sure.
So I'm the new president and CEO for Shepherd Pratt Health System. I just want to take a couple of seconds really to acknowledge the wonderful work of the staff. I think this is always complicated work, and I think we have very much appreciated working with such knowledgeable as well as very facilitative staff in terms of thinking about what is the public's need. And I think on behalf of the health system, we would also just like to thank you all for the time and effort that you've provided in terms of looking at this application. We have every desire to meet the state's need as it comes to this patient population, and I just want to say hello and look forward to working with you all in many different respects. Thank you.
Thank you. Move to agenda item number 4, certificate of need for Green Spring Station Surgery Center. The Johns Hopkins Surgery Center Series has applied for a certificate of need to establish an ambulatory surgical facility at Green Spring Station in Lutherville, Maryland. Kevin?
Okay. The applicant is Johns Hopkins Surgery Centers Series, the ultimate owners of which is the Johns Hopkins University and the Johns Hopkins Health System. This project would occupy 27,000 square feet of a newly constructed medical office building at the Green Spring Station development. It would be an expansion of the current significant Johns Hopkins presence at that location. Already in place at Green Spring are 65 primary care physicians and over 200 specialists handling over 400,000 visits annually. I should say that Commissioner Metz did a lot of work on this project before it was turned back to staff. We had initially LifeBridge filed comments seeking interested party status, at which point Commissioner Metz was appointed to decide whether they qualified, and he decided that they did, and had begun doing this review, gone quite far in this review, until a fairly recent development where LifeBridge withdrew, so the analysis reverted back to staff. He just gave me back a big stack of papers that those of you who have done this can appreciate. The estimated project cost is about $16.3 million. It would be funded with just under $2 million in cash, about $13 million in loan agreements with the Hopkins Health System, and $1.4 million in tenant allowances from the landlord, which is Johns Hopkins Suburban Health Center, LP. The rationale and drivers for this project it is the outcome of a planning process in which Johns Hopkins projected future utilization for its existing inpatient and outpatient regulated settings, and a comprehensive review of its operating room capacity, and concluded that it's essential to develop a freestanding market-priced operating and procedure room capacity to enable surgical care to be shifted to settings where it can be provided in the most cost-effective manner. The goals for the project were to increase access to the specialty physicians at Green Spring Station, increase the retention of patients within the Hopkins system, to move care for patients who could be safely cared for in the community to a lower cost setting, to improve convenience for the patients, and provide adequate space to accommodate existing volume as well as anticipated future growth. Need for the project was demonstrated in I believe, a very methodical and data-driven analysis of referrals, surgical use rates, retention rate of surgical specialties based on their availability at Green Spring. and those projections did bear out the need for 5 ORs, even if the retention rate of referrals was lower than ultimately projected. The impact, there's very little impact on other providers. This is mostly a reallocation of surgical cases within the Hopkins system and part of a larger strategy to reallocate resources and patients to more efficient settings. Consumers and payers should see a significant savings by the shift from the hospital operating room to an outpatient setting. In summary, staff recommends approval of the project as it complies with the applicable standards of the General Surgical Services chapter of the State Health Plan, has been shown to be needed, viable, and a cost-effective alternative for meeting the project objectives, and should have a positive impact on the cost of the healthcare delivery system. Staff also concludes there would be very little impact on other providers outside of the Hopkins Health family of providers, and that the project offers a cost-effective alternative to the status quo with respect to outpatient surgical services in the Baltimore metropolitan area. And so we recommend approval.
Can I get a motion to approve the CON? Second? Second. Are there any introductions?
There are representatives here. Gil Wiley, the president of Johns Hopkins Medical Management Corporation. Ann Langley, senior director for health planning and community engagement. Spencer Wildonger, the senior project manager, their consultant, Andy Solberg, and their counsel, Marta Harding.
All right, let's open it up for questions and comments. And maybe let me just start, Kevin, around the whole issue of the cost-effective alternative. So as I read the recommendation, I guess the way that I see this, there's a critical question of what happens in GBR to the space that's released at Hopkins, where surgery might have been performed in regulated space, now that it's going to unregulated space. And how I read what this is that there can't be a guarantee that total cost will actually go down because HSCRC hasn't addressed yet how it's going to account for shifting volume to a lower cost unregulated setting. Is that the correct interpretation of where we stand today?
That is the correct interpretation. I think there's the belief on all sides that the GBR will be modified to reflect this, but I don't believe that they've made a decision on how that's going to be done yet.
And any sense of timing of that or clarity of when that will happen?
I don't have that. I don't know if anyone on the applicant side would be aware.
Okay. All right. Other questions or comments? Okay.
We'll certainly remind them of that, the need to do that.
Yeah, I think it's an important issue. I think it's just that as we're kind of looking at other options for this, I think from the total cost of care perspective, we have to look at the big picture. Okay. Seeing no other questions or comments, call for a vote. All in favor? Aye. Any opposed? And for the record, I will abstain on this. Next agenda item is to approve release of MCDB data to the University of Maryland School of Public Health. Leslie Lebrecht will present the staff recommendation regarding the University of Maryland School of Public Health Health Services Administration's request for access to the MCDB. Leslie?
Good afternoon. I'm also here is Dr. Dylan Roby, Assistant Professor of Health Services Administration. To answer any questions. Release of the medical care database requires review and approval of the commissioners. I will briefly list the criteria for evaluation used by the Data Release Committee and further detail of the University of Maryland application. Lastly, the University of Maryland Institutional Review Board requires recognition by the Commission. The Data Release Committee reviewed this application and determined that this application and determined that this application is an appropriate use of the medical care database, that this applicant is a qualified user and has experience using this type of data, and that the applicant has the capability to appropriately secure the data for qualified users and understands the restrictions and limitations on re-release and reporting of the data. The Data Release Committee determined the study to be an appropriate use. The University of Maryland Health Services Administration is a department within the School of Public Health. The Commission entered into a memorandum of understanding with the School of Public Health in July to examine the current state of healthcare needs in the 5 rural counties of Maryland's Middle Shore region, and make recommendations to the General Assembly on approaches for effectively meeting healthcare needs in that region. This new application would examine variations across Maryland's geographic areas and demographic subpopulations in terms of healthcare spending, total cost of care, referral patterns, quality of care, ambulatory care sensitive utilization, and health services use over time. The medical care database would be used to see if physician practice patterns drive these variations and also how variations may be driven by population characteristics, provider availability, environmental and economic differences, maternal age and child development, and implementation of programs such as hospital approaches to global payment incentives. The Data Release Committee considers the applicant a qualified user. The principal investigator, Dr. Louisa Franzini, and faculty members in the Health Services Administration have experience using administrative claims and eligibility information and have used Texas Blue Cross Blue Shield and Medicaid data to study geographic variation in medical costs and use in health services research. They have used very large survey data sets, including the Current Population Survey, the American Community Survey, the National Health Interview Survey, and the Medicare Current Beneficiary Survey. They have experience using the Agency for Healthcare Research and Quality's Healthcare Cost and Utilization Project data, as well as other state inpatient hospital discharge data sets. They have worked with claims and encounter data from commercial insurers and Medicaid to conduct large-scale evaluations of programs to improve quality, reduce spending growth, and increase healthcare access. The Data Release Committee determined that the data security and management plan is adequately robust. The medical care database will be protected using adequate virtual and physical safeguards, as well as employment of appropriate cell size limitations when reporting findings. This application requires Commission approval and Commission recognition of the University of Maryland College Park Institutional Review Board, which approved this study. The Data Release Committee recommends data release of the Standardized Research Identifiable File of Private Claims for calendar year 2010 through 2014, which contains eligibility records and claims for professional services, institutional, and pharmacy claims. No direct identifiers are in the data, such as name, social security number, birth date, and address. Member IDs are encrypted by the payer and re-encrypted to permit linking across the medical care database files in years, but does not make possible linking beyond the medical care database files at the member level. The DUA prohibits re-identification of members as well as individual payer identification. As part of the application approval, recognition of the University of Maryland College Park Institutional Review Board is required by the Commission. The IRB is registered with the U.S. Department of Health and Human Services and has an approved federal-wide assurance. The IRB has determined this study to be minimal risk based on an appropriate risk-benefit ratio and a project design wherein the risks have been minimized. So two actions are required: approval of the data release and recognition of the IRB.
Can I get a motion to recognize the IRB? Motion. Second? Second. Any discussion or comments? All in favor? Aye. Any opposed?
This is just a mandatory abstention.
Okay.
Happen to be on the
Noted for
faculty.
the record. So the IRB has been approved. Now for the application for access to the MCDB. I need a motion to approve. And I heard a second. Okay. Any discussion or comments?
Yes, I'd like to. Everything sounds very kosher and straightforward here, but it also sounds like a very interesting study. I had asked a professional courtesy that when the manuscript is ready, even if it gets a little, we all know how long it takes to get things published, that we actually get to see the results, because these are interesting data, interesting hypotheses, and I think very germane to the responsibilities of the commission.
You hear that, Dylan?
I think that I want to thank the commission for supporting the request, and thank Linda and Leslie for all their work in shepherding the scope of work through. I think you'll notice in the scope of work, just as you pointed out, that it is a project that will have relevance for the state of Maryland, but also nationally in thinking through innovation and use of global budgets and that sort of thing as well. So we, when working with the staff, decided to work in partnership. So the idea is that we might be able to co-author journal articles, and certainly would be sharing this information with staff as well as with the commission to guide future work, but also to provide feedback to the commission about progress in terms of healthcare costs and spending, geographic areas to focus on, subgroup analysis to focus on, but also looking at the rollout of the ACA, the market changes according to the ACA, but also the global payment waiver and how it's affecting healthcare costs in the long term.
Great.
It's a great opportunity.
Thank you.
Thank you. Any other questions or comments? All in favor? Aye. Aye. Any opposed? You have your request approved and extension noted. Moving to agenda item number 6. As you will recall, we had a state health plan for facilities and services, the Organ Transplant Services chapter. The draft chapter was posted for informal public comment in May. 2 organizations commented, and then we had a discussion in the July meeting, and there was a recommendation from the commissioners to reconvene the work group to discuss some of the issues concerning supply and demand and how to improve access. And Eileen Fleck will now present the proposed permanent regulation and predominantly focus on what's happened between the July meeting and today.
Great, thank you. Good afternoon, Mr. Chair and Commissioners. So on this slide, I've just put down the key concerns that were raised at that July Commission meeting, looking at the disparity between the supply and demand for organs, the docketing rules, and whether or not those continue to make sense, and the threshold volume standards. We asked the work group to consider those issues at a meeting that was held on August 31st. Staff invited Commissioner O'Grady to attend that meeting and participate in the discussion, which he did. And on the next several slides, I'm going to review the discussion by the work group and then recap some of the differences between the current State Health Plan chapter and the proposed State Health Plan chapter before asking the Commission to adopt proposed permanent regulations. So essentially, the work group decided that Certificate of Need regulations may not be the most appropriate way to address this issue of the disparity between the demand and supply for organs. There are a few reasons for that. I'm sorry, I'm like missing a page out of order. Okay. And so one reason is that the certificate of need regulations are for organ transplant programs, and these operate separately from the organ donor solicitation programs in order to avoid ethical conflicts. Also, there are already these organ procurement organizations that are dedicated to encouraging organ donation and coordinating that process. So we think that broad-based efforts led by national foundations, organ donation solicitation organizations, donor hospitals, and the federal government have greater credibility and visibility in terms of addressing that issue. There is some evidence that policy changes are being considered at the national level that could result in an effective increase in the supply of organs. It was mentioned at the work group meeting that there is a national initiative underway to reduce the number of discarded kidneys through changing the performance metrics for evaluating programs. That would be on a pilot basis. The concern is that the current measures of graft survival and mortality may be resulting in risk aversion to transplanting some of the kidneys that could be successfully transplanted and benefit patients. Another issue that was raised by the Commission is the docketing rules. On this slide, I've summarized a key part of the docketing rules. Essentially, the Commission shall only docket an application if existing organ transplant programs have been in operation at least 3 years and are meeting threshold case volume requirements, with 2 exceptions. The first is an organ transplant service has been designated by the Organ Transplant and Procurement Network as a member not against stat means, which would be if the outcomes were poor. If it was a poor quality program, we wouldn't consider the volume of that program. Or the second exception would be a recently established organ transplant service located outside of Maryland that fails to meet and maintain the minimum volume requirements that would apply to a similarly situated program in Maryland. The threshold standards referenced I've shown on this slide. At the July Commission meeting, it seemed like primarily the concern was about the kidney standard and whether or not that was too high. So at the last work group meeting, members did not express concern about the rules unfairly shutting out applicants or negatively affecting access to transplant services. It was noted that it would be more cost effective to have fewer programs at higher volumes. Johns Hopkins Medicine, as I mentioned at the July meeting, they submitted informal comments proposing that the threshold standards be eliminated from the docketing rules, while maintaining that requirement that a new program be given 3 years to get established before additional new programs be considered. In response to that comment, we recommended keeping the threshold standards in the docketing rules, but proposed using the average annual volume over a rolling 3-year period instead of just 1 year. And Johns Hopkins has continued to express concerns about the threshold standards. Following the work group meeting, it proposed entirely deleting the docketing rules. However, we continue to support inclusion of the docketing rules. At the most recent work group meeting, there were no proposed changes to the threshold volume standards, although a few members expressed some comments that the standard for heart seemed a little bit high. The threshold standards are consistent with maintaining organ transplant programs that operate at least at the minimum volume standards, because if we have a program that's operating below the threshold standard, it's likely that if we add a program, we think at least one existing program is going to go below the minimum standards based on having about the same volume and then just distributing it among more programs. Based on the volumes at existing kidney programs, we're not expecting that the threshold volume standard for kidneys will be a barrier to accepting applications. Johns Hopkins Hospital and the University of Maryland, the 2 programs in Maryland, have a long history of operating above the threshold standard for kidneys. For over 2 decades, both have performed at least 50 kidney transplants annually. The University of Maryland Medical Center has been at over 200 cases for, I think, about 2 decades, and Johns Hopkins Hospital has been doing over 200 for about 7 years. In the District of Columbia, since 2009, Georgetown University has been performing over 50 transplants per year. Recently, in 2015, that volume jumped to over 150 cases. That's because the other MedStar-affiliated hospital, Washington Hospital Center, shut down its kidney transplant program and consolidated it to Georgetown. So the other existing kidney transplant program in the District of Columbia is at George Washington University. That became established in early 2015, and it performed 31 transplants in 2015. And then in the first 8 months of calendar year 2014, it performed 40 cases, which would put it on track to perform over 50 cases in 2016. In Virginia, I know Fairfax Hospital is the only location in the health planning region for Maryland with a transplant program, and it's performed over 50 kidney transplants every year going back to 1998. So we're not concerned about the threshold standard being too high, and it's not something that the work group expressed a concern about. In terms of the other aspects of the docketing rules, the requirement that we have programs established for at least 3 years, we do think that if we don't have that requirement, then there won't be sufficient information and data to evaluate the program's operation and make a good decision about whether or not we should be adding a new program. We also think that potentially if we're adding a new program when we just recently approved one that's been in place for less than 3 years, that could compromise the ability of that new program to reach the minimum volume standards. So because of having a program recently established in DC, the George Washington University program, less than 3 years ago, with what we proposed, it would be the case that applications for a new kidney transplant program could not be accepted until January of 2018, which is about 15 months from now. In terms of proposed changes, the work group just had a minor change related to the threshold standards. They asked that the title of the table be revised to better align with the wording in the docketing rules that references a 3-year annual volume rather than the annual volume. And so we made that change and a couple other minor changes to the language. The specific changes were provided as an appendix to the memo that staff sent to commissioners. In terms of opportunities for new programs, that was a concern raised at the July Commission meeting. We do think that there are more opportunities to potentially consider a new program under the draft proposed regulations. The draft state health plan chapter eliminates the need projection, which serves as a barrier to considering the new program based primarily on just the utilization trends and the population growth. Also, the threshold volume requirements for kidneys are explicitly for adult transplants, so we don't have to be concerned that the pediatric-only program at Washington Hospital Center would be a factor when looking at whether or not to docket an application. Also, transplant programs of questionable quality with low volumes would not interfere with consideration of new programs since we've incorporated that into the docketing rules. And lastly, the draft state health plan chapter eliminates the requirement for affiliation with an academic hospital, so other types of hospitals could also have a transplant program potentially. That concludes my presentation. I'd like to request that the Commission adopt draft COMAR 10.24.15 as proposed permanent regulations. I would also be happy to answer any questions.
Can I get a motion to approve the Organ Transplant Services Health Plan Chapter? Second? All right, let's open it up for discussions and comments. Just first frame, I think we were kind of in the process in July meeting to really, rule on this, and there were a number of substantive questions that were brought up. I just commend staff for kind of taking those questions and getting resolution of that in a very sort of practical and timely manner. So appreciate that.
Thank you.
Commissioner O'Grady, any comments as to?
Yes, a few in thinking about this. I mean, my main concern at the last meeting was the idea of what we saw in the data, which was that roughly 900 transplants are done on Maryland residents. I guess is the right way to think of it. But there's a waiting list of roughly 4,000. And I went back to the national organization and asked for the waiting list to actual transplants done data for the last 15 years. And that effectively, that difference of maybe 25% of total need being met has been consistent pretty much over the last 15 years. We're seeing other growth that you can expect with the expansion of the obesity epidemic, next type 2 diabetes, the demand for kidneys, end-stage renal disease patients, that started to grow even more. Same kind of a pattern, a little bit with hepatitis C, given the treatment of and new screening of hepatitis C. So the demand for these transplants are there. I think I was convinced attending the work group meeting that in some sense what we have is, because of the focus of the way it's done in Maryland, which I think is consistent with the way it's done across the country, we have, our quality is very high. Our access, not so much. It's sort of, you have these people on waiting lists, and a certain percentage of them die every year waiting for a transplant. So it's a serious situation. most of the emphasis on this, with the exceptions that were brought up by Eileen, is really on, it's not so much on the transplant centers. It's on the donating hospitals. It's on different things, different kind of innovations you would want to start to address this long-term, persistent undersupply of needed transplants. I think that as part of that, in the July meeting, I also brought up the idea of kind of that some of these docketing rules restrain new entrants coming into the system and may have an anti-competitive effect. And the Hopkins letter seems to concur with some of those concerns. The staff, and I'll put words in your mouth and certainly correct me if I've got them wrong, feels that still the docketing rules have a value in making sure that you don't end up with too many providers and sort of not a critical mass of transplants being done at any one of them. That's not my first sort of notion here. I tend to think that open competition is better than a closed system, but I certainly understand their argument. Like as I said, my main concern is these waiting lists and bringing that down, and I would like to come back to the commission with some other ideas as they develop. But I think the commissioners in all, just for your own vote at this point, this is a notion of saying that as long as the current players don't, and again, correct me if I've got this wrong, as long as they don't drop below certain levels, nobody new gets into the system. I understand the staff logic. I don't know how totally comfortable I am of telling players that they can, if they think they can help in this area, and I'm not sure I agree with the assumption that there's just a fixed number of donors out there and that new people might not spur additional donations. So as you consider your vote on this and the kind of the Hopkins alternative that they're suggesting of just what is the value, what real value in a policy sense are we getting from these docketing rules? I just, that sort of is still up in the air. And certainly, Eileen, if I've short-shrifted your argument and logic of why we need these sort of thresholds, or our current players to drop below these thresholds, before we think of anyone else, I'm all ears.
Well, I just want to make a small correction. So it's not that if they drop below, that's when we consider a new program. It's that we can't consider new programs unless everyone stays above a certain level. So right now we're expecting like everyone will stay above a certain level and we could consider new applications. Right now we think the only issue that would be blocking a potential new application has to do with the newly established program, which hasn't been in place 3 years. So it's a matter of, I just want to be clear on that, like as long as programs stay above a certain level, we consider new applications. We're open to that.
What happens if programs drop below those thresholds?
Well, if it goes below 50 for a program, then at that point, yes, like potentially we wouldn't be taking new applications unless it was of poor quality or it was a program that was newly established, which is GW at this point, that isn't meeting the minimum standard. So if it would have to go below the minimum if it's a new program for us to then say we're not going to consider that, because in Maryland that would be considered for closure.
Okay, and I guess in my logic of thinking about the kind of, from the health economics sort of perspective, the idea of sort of saying that we will guarantee you a market share unless you're really poor quality is troubling. The idea that you're guaranteeing certain players a role in the market unless they really do poorly. But clearly you have a different opinion of this, and I'd love to hear it more.
Okay, well, I mean, I guess also add that, like, we do see this as a cost effectiveness issue. Like, our concern is, do we want to duplicate resources, right? Like, have extra programs that we don't need because it's very expensive to establish a new program. So if existing programs are doing well and they're good quality, it seems like, do we need to have another program and split the volume? I mean, there is also a concern about the financial viability of a program. I think it's hard, like we did try to get from the work group in an earlier meeting, like, what's financially viable in terms of like a volume, which is hard for them to pin down. But I think it was said that, the minimum, probably not. It's probably something closer to the threshold standard in terms of at least the financial viability of a program.
I understand that logic, and I think it held up much better in a fee-for-service world where you were concerned that you didn't really have control over some of these. I'm not sure I'm totally convinced in our sort of new world where competition, because you're sort of saying competition will lead to additional spending, and in the fee-for-service world, that did happen. I'm not so sure it would happen today, but my other commissioners have lots.
Let's go around clockwise.
So just very briefly, there is some science to suggest that there is a certain volume that is associated with maintaining the whole transplant team and infrastructure. That is important. So I'm assuming that is indeed part of the rationale justification. To my colleagues' concern, in the state of Maryland, do we know what proportion of the population are designated organ donors?
I thought it's around 50% based on the DMV records.
50% of the state of Maryland.
Okay.
I think that's probably pretty good relative to other states. But could we do better in the state of Maryland? Absolutely. And whose job is that? To increase the number of individuals who are organ donors.
Well, I think the organ procurement organizations, they try to encourage that and to encourage hospitals to solicit more donations, to encourage organ donation at hospitals.
And the last thing, when you think about the fact that for some of those organs you need matches, do we have disparities in who's an organ donor and who's not? I would suggest that you'll see racial and ethnic disparities, and targeted efforts in certain populations could help increase the number of possible organs.
Right, that is a possibility. We did include some information on that, I think, in the draft regulations in terms of historically there's been a difference in that it's gotten a lot better in terms of like African Americans and other minorities participate in donation, but then the need is much higher for those populations too. And I think with the living donors, like for kidneys, that there actually is still everywhere a significant disparity. Like there's not really a place in whatever study that looked at the issue that was doing well, that was saying, okay, it's totally even in terms of different ethnic groups.
Are there questions or comments?
We went around on this last time. We had a pretty spirited discussion and debate. I think you have done a remarkable job in trying to meet some of the concerns. I'm just going to say for the record, I share Commissioner O'Grady's reservations about this. The evidence is overwhelming. There's a tremendous demand for transplanted organs. My recollection is it's just simply enormous. And in reading Anne Langley's letter from Hopkins, her concerns, I think, are still legitimate. Again, I don't want you to take this the wrong way. I think that the staff has done the best they can, I think, trying to accommodate this, but I'm very uncomfortable with any limitation in a matter of like this, especially when we're dealing with life and death.
Other comments? Oh, Fran?
Yeah, thank you, Mr. Chair. Thank you, Arlene. And unfortunately, I missed the spirited discussion in July, and I'm trying to catch up now. But I have a technical question, and it has to do with pediatric transplants. So I see the threshold specific for kidney transplant, but not for any of the others. So were there considerations in looking at, of course, the special needs of pediatrics as far as the transplant team and how to dial that into these other thresholds, or was this for all ages?
Well, I think because the volumes would be so low in those areas that the work group didn't think it made sense to have thresholds. And even actually for pancreas, like that was a change where people felt like typically the volume is so low that we're not going to have a threshold. It used to be 12, and they said, like, let's just not have a threshold for that one. So that was the thinking on it. My understanding is that CMS, in terms of certification, they would want to have certain expertise. And so they would be the ones making sure that if someone is a pediatric program, that they have the right people on staff with the right experience to, you know, do a good job with that population.
Okay, thank you.
Obviously, an area that everybody's very concerned about. I'm an organ donor. Probably most of the folks around the table are organ donors. A couple comments and maybe a question. I mean, obviously we're Dr. O'Grady and Dr. Moffitt concerned about the overwhelming need for organ transplants. There's nothing more heart-wrenching than to hear about somebody who needs an organ and didn't get there in time, and somebody passes away. It seems to me in healthcare, and you can right, wrong, or indifferent, or unfortunately, that it comes down to a couple different things. We're all in the business of trying to make sure that we promote the highest quality possible, right? But at the same time, no margin, no mission. So with the thresholds in place, I mean, is the overwhelming concern there that the thresholds need to be in place so that there's a prevention of, I don't want to say unsavory or unqualified applicants into the market that provide these services, so that we keep a certain threshold so that the quality providers can, for lack of a better term, make a profit on such ventures? Because in healthcare, I know there's some charitable work, but there's also no margin, no mission. For very long, if healthcare entities can't at least break even doing transplants, they won't do them. That's a sad reality of life. Is that how that mixes in there?
Well, I would say that the work group found it difficult to really say at this volume we won't be financially viable. Like they weren't comfortable. Like it seemed like it wasn't an easy question for them to answer. I feel like it has more to do with avoiding duplication of services and looking at the impact on other programs. So if we're going to add a new program, we want to consider, is it going to cause someone to go below the minimum thresholds? Is it going to jeopardize an existing
So what
program?
you're saying is the folks that participate in these type of programs believe that they are conducting as many transplants as is feasibly possible at this time?
No, and that's the other issue. So the existing transplant programs would say, like, well, the existing programs can't expand to meet demand potentially, and so, you know, again, even if, like in our current regulations, we have a projection for, we think this many new cases will occur beyond, you know, what the programs are doing. Potentially, there's this need that could be unmet. But the existing programs, you can see sometimes that it really fluctuates from year to year. Maybe suddenly they do another 50 transplants or another 30 or 40. And obviously, like, they could do that. They could handle that increase in volume. So it's not something that's easy to pin down.
Things with I'd have to think that with Johns Hopkins, being the premier health provider on the planet, wanting to see thresholds eliminated, it's pretty moving, because you know, I tend to think if I had that type of condition, it would be a place where I would go to maybe get a transplant. So you know, I kind of share the concerns of the other commissioners when I had this question. But thank you, because it's not an easy area, and I'm sure that it's an emotional area and an area that also has a lot of work.
Other questions or comments?
The fact that we have very few available donors, and you have 3 transplant centers within a 5-mile radius, I assume they're in the same national region?
So we have, the way it works is there are these donor service areas and these organ procurement organizations, and so there are 2 that cover Maryland. And
but are these 3, GW, Georgetown, and Arlington, in the same region? They're only like 5 miles away from each other or less.
So in one region we have the 2 Maryland academic centers, and in the other region we do have the ones that are in Virginia and the District of Columbia.
Are they competing for organ donors in a sense?
The way it works is
too much competition will promote transplanting less than perfect matches. And who makes that decision about the matches? Is it the national networking, or is it the individual hospital accept a kidney with a certain type of match?
So there are national policies in terms of the allocation system and the wait list system, and who's higher priority and what the best matches are based on all the patient information. There have been changes over time. It used to be that it was pretty much driven by the local organs. Like if the organs became available locally within the same OPO, then the people that need them within that OPO, they're the first priority. It first goes to someone, you can look at the list and see who it should go to. And then at that point, like it would go to the region. And then at that point, if it's still no one's taken it, then it goes national. But there was concern that patients that are harder to match, which is often the minorities, that they're getting shortchanged by this system. And so the policies changed to give higher priority to the people that are in greater need, that are harder to match. And so more organs now would go, I guess you could say nationally first, like they would go first to whoever is at the top of the list that needs one, as opposed to first staying local before considering who in the nation needs one the most and is at the top of the list and is like the best person for a particular organ.
So it's not going to promote unhealthy competition among those three transplant services?
You mean adding the program, or I'm sorry, what was your question again?
Well, you're concerned about thresholds and having three programs so close to each other. Will they be able to meet those thresholds in reality in the long term? And is there excess competition for donors that would create a less than perfect, accepting a less than perfect match?
It's hard for me to, I guess, comment on the practices in terms of like accepting organs. I think at this point we're not concerned about the number of programs or their proximity. Like, I think that they're doing a healthy volume. They're well above our thresholds, as I said, and so like we don't think there will be an issue with the 50 threshold for kidneys in particular. It's hard to predict how a new program would influence things.
Do you mind if I just address the?
Let me let Randy go first, and then you can go. Thanks.
The problem with sitting on this side of the table in the clockwise rule is that the Commissioners O'Grady, Thomas, Muir, Moffitt, Flaggo, all the good comments have been taken. So, here's a question about the docketing rule, about which I continue to be concerned. The concerns that you would water down existing programs or take volume away and they wouldn't be able to do it as cost efficiently and all those things, if you docketed the application, are actually something you would also consider in deciding the merit of the certificate of need, aren't they?
Yes, I mean, the idea is just primarily to like look at the impact on existing programs, and because we see it as, okay, if a program was newly established and hasn't been around very long, potentially that program's going to go below the minimum if we're considering a new program already when one just opened less than 3 years ago. Or, if that's not true, but like there's one that's below the threshold, we're concerned that adding a new program will cause that program to go even below the minimum, what we see as the minimum standard.
But assume there's no docketing rule, that the regulations are enacted as is without this docketing regulation. Everybody can docket their application. In evaluating the certificate of need, we would be able to reject a certificate of need application if we thought it was going to unwarrantedly force one of the existing programs below these thresholds.
Yes, that's right.
So the docketing rule really doesn't substantively change the outcome as much as just say, we're not going to even look at this application.
Right, because the idea is we think it's unlikely it would get approved, in the current environment, and we think it's helpful to applicants to have them not go through all the planning and the work and the costs associated with this. If we feel like there's a way to, upfront kind of signal, we think it doesn't make sense to add any program under these circumstances.
And I guess that's my concern is if we thought of all the circumstances and said, no, it's clear as day, or if we come up with a rule that sort of roughly seems it just unlikely could be just a 51% chance of not getting approved, and applicants may want to try their hand at 45%. Maybe they have a better way, better program. Maybe they can make a case that the existing guys aren't doing so great, and they should lose business to their new program. I guess those are, I haven't seen that, and I don't mean for sure, I haven't really seen an analysis that way presented to us, that we've gone through all of the alternatives that someone might come up with and decided that they're not even worth hearing about. I think that's my concern with not so much the 3-year requirement. I see that one gives folks time to come up to speed. But with the other one that you have to meet minimum thresholds, it seems to me that we're talking, if you keep the one requirement for 3 years, we're talking one application every 3 years as it is. I'm not sure why we really need the threshold. So it's really saving us that much, and it is sort of foreclosing, I think, at least an opportunity for somebody to do something better. And I see the point that we don't think the rule is practical, effective to make any difference because we're all about the thresholds. But in that case, do we need the rule?
Well, like I said, the idea is that we think potentially if we have a program that's below the threshold, that adding a new program will cause it to go below the minimum standard, which we see as something that would not be acceptable because, CMS has this minimum which we're consistent with, and, we'd be concerned about the skills of the surgeon and the staff, and it's just, probably financially it wouldn't be that viable either at such a low level. So I guess our judgment is that if someone is below the threshold, then, we become concerned that they'll go below the minimum if we're adding a new program, and that definitely wouldn't be a good thing.
And I can ask one final one, and I'm finished. You referred to low-quality programs not counting towards the docketing standards. Is that? And I was looking at the rule, and the only thing I saw that seems to touch on that is that they excluded organ transplant services not in good standing with the organ transplant procurement network. Is that what you're talking about?
Yeah.
But if they're not, if they're below the threshold for other reasons than whether they're in good standing with the organ transplant procurement network, our docketing standard doesn't look at that.
We did want to pick, I think, of a standard that was clearly below that indicated like long-standing problems with the program, because so often a program, maybe it gets flagged and it didn't do so well for a 6-month period, which I think is kind of the rolling period that gets looked at. But then, they improve. Maybe CMS does have to step in. Maybe they do some root cause analysis and they figure it out. And so even though they were flagged and they looked bad in terms of the CMS metrics, they came back up to the level they were supposed to be at. So it's actually, it is pretty rare that someone isn't able to get back up to the standards they should be at. And so, it seemed to us that it made sense that CMS gives people a long time to improve and get up to the standards they're supposed to be at, and we should be consistent with that.
But in this particular case, the way our docketing rules, the proposed would, and I do want to recognize that you've made this a much more open system than it was prior. So it's a question of, is there a little bit more to do here? If I heard you wrong, correct me. But it sounds like that once we've already said yes to somebody, the effect of the docketing rules, it keeps everybody out and any other new entrant out of the market until that person has had 3 years to come up to speed. Is that correct? So when Randy was asking about kind of, if it's here, if it's not here, what difference does it make? It means anyone else is effectively told, don't bother to apply until that 3-year run out goes on. Is that correct?
That's correct. I would say that.
But that's the difference. You can't move in.
That's one of the two. Either
right.
3 years, or if somebody, even after 3 years, somebody's below the threshold, then you can't.
Right. I would note that for cardiac surgery, we do have in those regulations that for new programs, we're not going to consider a new one for 3 years after we approve a new cardiac surgery program. So it's something we have done in regulations before, but obviously, it's up to you as to what we should do in this situation.
So low volumes don't put your program at risk?
In organ transplant or cardiac surgery?
Organ transplant.
If it's a new program, you would be expected to voluntarily shut down if you're not at the minimum volume standards. You're supposed to get up to them, I think, within 3 years, and you're supposed to continue to maintain them.
It doesn't shut them down. It just means you would allow somebody new to come in. Is that correct?
No, a new program, if they're not meeting the minimum volume standards, I think they could make a case. They could maybe come up with a plan as to what they're going to do to get to that. But if they're failing, like if they have a plan or they try to do it and they fail, then the expectation is that they will voluntarily shut down because they're not even at the minimum.
Yeah, we have actually exercised that authority, not in cardiac, not in organ transplant, but in cardiac PCI services. We've asked programs to give up their authority. So we do actually take that seriously.
So let me just frame a little bit where we are. It sounds like with the docketing rules, it's a little bit of a trade-off of which downside you're worried about more, the downside of not having competition into the market or the downside of potentially sort of taking volume away from existing players and going below some of the threshold case volume. We have a process in which we went to the work group, but I think Johns Hopkins was not at that work group meeting.
Well, there was a representative there. The person who was there was the replacement person for someone who historically participated, and she left for work at another organization.
But not the same level of.
Yes, I mean we did our best to try to keep this person up.
No dispersion on staff.
Yeah.
Just outlining the piece. And right now we have at least 6 or 7 commissioners who've expressed some concerns around the docketing rules. So we have a couple of different options. I mean, we could say, let's just try to, pass this without amendment. The chair could entertain a motion to amend this without the docketing rules, or we could say, we've got this real concern, go back to the work group. I'm open to hear, or I'll just make a recommendation which way we go. So.
Could I just say one thing? So, I mean, you mentioned that the docketing rules in terms of protecting the existing players, but the way that the work group thought about it, and we think about it, is the cost effectiveness issue. Like, is it cost effective to add a new program, which is very expensive to establish, if the existing programs are pretty good and they are, meeting the demand to the extent that they can, given the limited supply of organs. So, I just want to be clear that what the logic was.
Great point.
One theoretical question. Yep. If every state adopted what you proposed, then there would never be a new entrant into transplant, ever, right?
Well, I'm not sure why you would say that.
Because if there's a 3-year rule, and every state said you had to have a 3-year rule, then no one new could ever get in because they couldn't meet a 3-year rule. We're asking another state practice there and come to us after 3 years, right?
No, I wouldn't say that. Like, it really just pertains to our health planning regions. And so it's only if within our health planning regions, someone establishes a new program within our health planning regions, one of the two, then we wait 3 years before considering a new program. So like right now we could add a new program in Maryland because within one of the health planning regions, because we have the 2 academic medical centers, there hasn't been anyone new in that health planning region, the one that has Johns Hopkins, the University of Maryland. So potentially, except for the fact that we have need projections and it doesn't work out in the current regulations, but in terms of the volumes, it's not an issue in terms of having a new program. There hasn't been one for a long time in that one health planning region.
But if the University of Maryland decided to open a satellite down in the DC catchment area, however you want to think about that, they have to wait till this 3 years runs out. They have to give GW 3 years protected before they can even make a move, before they can even apply.
Right.
And so that seems to me kind of a close, as you were sort of implying, the regular players get a little extra protection before new players in that particular market can come in. Planning or restraint of trade?
So one question we haven't really addressed was how would the regulations be affected if the draft proposed regulations be affected if we just struck the docketing requirements? Would there be gaps, which is my guess, that would require us to go back and rework these?
Well, I think that we should put something in terms of if we're going to have a review schedule, if there's not going to be a review schedule for applications, what the process would be. I think that would be helpful. I mean, I think the work group did like the idea of considering quality of the existing programs, I think it would be okay.
Yeah, the short answer would be, would the regulations be incomplete, forgetting for the moment the issue of docketing, would they be incomplete if we struck that? Would there be other elements of the regulations that would be unclear, that would require us to go back and fix those before we could feel comfortable about publishing?
I don't think so. I think we have included in the standards what our expectations are for evaluating applications.
All right, if that's the case, the chair would entertain an amendment to the motion to strike out the docketing rule. Is there a second? Okay. So let's have a discussion of that before voting on the amendment. Any other discussion on that? Yeah, so we're voting now on the amendment that we would amend the motion.
Just a clarifying question. We're striking the regulation .04, that whole regulation.
Mm-hmm. Yep.
So my clarifying question is, in doing so, would organ transplants be a special case? We have these docketing in other areas, correct?
Sometimes, but not always.
Okay.
Not a unique case. Other questions or comments? All right, let's call for a vote for the amendment to add that we would strike out the docketing rules out of the state health plan for organ transplant services. All in favor? Aye. Any opposed? Okay, so the amendment has been approved. Now let's vote for the amendment. Well, we approve the amendment, so we don't actually have to do the motion now. So let's now just vote on the amended state health chapter for organ transplant services. All in favor? Aye. Any opposed? Okay. You have your amended state health chapter.
Thank you.
Okay. Yeah, but that's just one thing. Okay. Exactly. Let's move to agenda item number 7. Aaron Dorian, Chief of Government and Public Affairs, is going to provide an update on the Rural Health Group and provide an update on the work group membership, and we will need to act to approve the new members of the work group. Aaron?
Thank you, Mr. Chairman, members of the Commission. I'm here today to provide an update to all the work that's been going on in the Rural Health Work Group and the corresponding study, and also ask you to approve a number of replacement members. So I just want to first remind you the purpose of this work group and the study. I want to tell you what we've been working on for the past 2 months, or, well, couple months, and then also talk to you about the next steps. So the Rural Health Work Group was, as you all probably remember, was established under Senate Bill 707. The legislation set some members in statute. These included members of the General Assembly, the Secretary, CEOs of several rural hospitals, and then providers, consumers, local government, business, labor, and other members approved and appointed by the Healthcare Commission. The purpose was to examine the purpose of the work group was to examine the challenges for delivering healthcare in the 5-county Mid-Eastern Shore region. These counties are Kent County, Queen Anne's County, Dorchester County, Caroline County, and Talbot County. The work group is also to review policy options developed under the study and make recommendations to the General Assembly on approaches for effectively meeting the healthcare needs of the residents in this 5-county region. So the study, which is to be done in conjunction with an entity that has expertise in rural health, is to examine the challenges in the healthcare delivery in the 5-county region, examine the economic impact of hospital closures or conversions, identify opportunities created by telehealth, the all-payer model, and other innovative care delivery models, develop policy options for addressing the healthcare needs and the delivery system in the region, and identify approaches for applying these policy options to other rural areas of Maryland. The chairs of the work group have discussed also using this as a way to provide some options for looking at looking at other areas in Maryland and applying a sort of study rubric for other areas if the particular policy options cannot just be replicated in other areas. So where are we now? We had signed the MOU with the University of Maryland School of Public Health and the Walsh Center for Rural Health Analysis out of Newark at the end of August. They have started working on the study. We have a data use agreement with them, and they have received the data from the APCD, and they've also received HSCRC discharge data. They are starting the study, and we meet with them. Staff meets with them weekly to talk about where they are. We held a Rural Health Summit on August 31st at Chesapeake College in Y Mills, Maryland, which is right off Route 50. That was a 4-hour meeting, half-day meeting, where we really looked at, we level set for everybody on the work group, sort of what the current status of the health system out in the 5-county region is. We also established advisory groups that will meet between work group meetings to look at particular policy options and make some recommendations to the bigger work group. These advisory groups are workforce development, transportation and access to care, economic development and economic impact of health facilities changes, vulnerable populations, health disparities, and populations with special needs. Two of these advisory group meetings have already been set. The workforce development work group will be meeting on October 21st, and the vulnerable populations, health disparities, and special needs work group will be meeting on October 4th. Again, the advisory groups will meet in October. Leaders of these advisory groups have been chosen by the work group chairs, and staff is working with these leaders to set the agendas for these meetings. The next work group meeting is November 1st in Cambridge. The University of Maryland School of Public Health and the Walsh Center will present their study plan to the work group. That's to get some buy-in from the work group before the cake is baked. They'll also get presentations from the two major health systems in the 5-county region, that's Shore Regional Health and Anne Arundel Medical Center. And the work groups that have met will report on their progress. In the intervening time, we had 3 work group members that cannot make the commitment to this group. So we have some replacement members. We also received a letter from the Talbot County Council that they felt that there was not enough membership from the Talbot County area. Just to go over the work group membership with you by county, the work group is 31 members. Before any of these changes, Caroline County had 2, Dorchester County had 3, Kent County had 6, Other Eastern Shore had 3, Other Maryland had 8 members, Queen Anne's County had 4, and then regional members was 1, and Talbot County had 3. The old membership list is provided on your table, and the new members that we are requesting that you approve are listed here. These members are Anna Ferreira, she's the Dorchester County Department of Emergency Services Executive Director, Dr. Frida Wadley, who's the Talbot County Department of Health Officer, Roger Harrell, who's the Dorchester County Department of Health Officer, and Doris Mason. She's the Upper Shore Regional Council. We already have the Midshore Regional Council represented, so she represents the Upper Shore. So with that, I ask that I can answer any questions, and I ask that you approve these new members.
Can you just clarify, I was just trying to follow the geographic balance. So with the adjustments, is it more geographically balanced now?
It's slightly more geographically balanced. Caroline County will have 3% of their membership. Dorchester will have 13. Kent will have 19. Other Eastern Shore will have 6%. Other Maryland is at 26%. And remember, some of these are because those are statutorily required to be on this group. Queen Anne's County will have 13. There'll be 13% regional will be 6%, and Talbot will have 13%.
Okay, great. Can I get a motion to approve new members of the work group? Second? Second. All right, let's open it up for discussion, and let's go counterclockwise. Terry.
Okay, I go first. I'm going to talk the most too. First of all, I'm kind of hard pressed to find these 6 people from Kent County.
So,
I see Bob Grace.
So Senator Steve Hershey, Delegate Jay Jacobs.
Oh, so you're counting states, they don't live in Kent County. I'm talking about Kent County people. They don't live in Kent County.
They represent, but they represent Kent County in the legislature. So I think that's a very important piece to note, that of all the counties, Kent County has more of their legislative representation on this work group than any of the other counties.
Well, you know, when this whole work group was born out of Senate Bill 707, which was a result of a movement that started in Kent County. I actually started it, and it just took off and ended up in the legislature, and there was a law passed. And yet, there are no positions from Kent County on this whole work group. And I was disappointed before. I'm disappointed again that we have 3 replacements, and again, we still have no positions from Kent County on this work group. And we're the ones who know the system best of anybody else.
So I think we have to remember that this is a work group to look at the entire region, not just one particular.
Right, but that's the other point. I hope this isn't looked at as just the development of a regional system. There were other options brought up in the meeting at the end of August, where let's not only think of regionalization, maybe we can decentralize these things too. That was brought up by the CEO of Garrett County Hospital. And I applauded that concept, because everything I see now seems to drift towards that this is going to be a regional center with disregard for the need for a hospital in Kent County.
So I want to remind you that we're not just looking at inpatient acute care hospital services. What really struck me during the meeting on October 31st was the great disparities, August 31st, I'm sorry, I'm moving ahead, was the great disparities in all of these counties in all sorts of services for all service lines. So I think we really need to get away from the idea that this is about inpatient acute care beds. Yes, that's a piece of it, obviously. But looking at this group and these members, and particularly these chairs, of which one is from Kent County and Chestertown, they really want to look beyond just the acute inpatient capacity and look at the capacity for all health services in this 5-county region.
I know, but living in the healthcare system right now, the culture is very Easton-centric. And all these counties you talk about use Easton Hospital for services, including southern part of Queen Anne County. That's basically an Easton market share. So the majority of these people you mentioned, even though they're not from Talbot County, they're from Dorchester, Carrollton, they're all Easton-centric people.
All right, so noted. Let's keep going around. No, you're missing your chance. Okay.
I respect.
You got it.
There you go. I respect that you put together this list, and you have a good amount of people who are willing to be on the committee. I think that takes a lot to find people who will take time out of their day to make this a priority to get it done. I want to express, however, that I think you're going to have a lot of group things, because they're all from the medical community. And
I'm sorry. Yeah.
I'm putting it out there that my concern is groupthink. That I think this is an issue that's going to require a large amount of creativity, and bringing people from outside the institutional knowledge has a lot of value to it. And it doesn't necessarily have to be done necessarily by the members, but bringing others into the group, and I think that's where the weight, I know you have a lot of community input sessions planned in this. I think that's where I want to see value added there, because it's not by the members of the community. I think you're going to have a lot of groupthink, and I have a concern about that.
So I think that's a very, very good point. You know, we have tried to get members, not only providers or certain providers, or we've tried to get members from a broad section of the community, and which is why I think it was important to add not just the Mid Shore Regional Council Executive Director, but the Upper Shore Regional Council Executive Director. We've tried to get business people, you know, we've tried to get public health people from a lot of different perspectives. I do want to remind the commission that we are having these advisory groups, and we're trying to fill those with additional, you know, that's not just for the work group members. We would like to have additional input from people that are not included in this work group, you know, so that we can get as many ideas to sort of percolate up, and so that the best ones can come up to the top. And so I definitely agree with you that we do need broad representation. It's been very, very difficult to make anybody happy. So maybe the fact that there are so many complaints is actually a good thing, because nobody seems to be particularly overly enthused.
I think it's a good sign that people care.
Yeah.
And in this day and age, when it comes to a multitude of issues that go on in our communities, too often that the state and city, counties put a lot of effort into trying to resolve issues, and nobody shows up to meetings. And the fact that I think you have people that show up to it and care very much about it, it's great. By just throwing it out there, I want to make sure that I'd like to see somebody who drives a bus, who actually drives these people to their doctor's appointments, come in and give you guys input.
So one thing that I did forget, if I may, Mr. Chairman, I know we're pressing for time, but one thing that I forgot to mention going through what this work is actually going to entail, we are going to hold public hearings in the 5 counties. And so the School of Public Health is also going to, in addition to those public hearings that are held by the work group, the School of Public Health is going to be doing stakeholder interviews and focus groups. So all of that is going to feed into the study and feed into the information that's provided to the work group. So I think we're going to try to the best of our ability to get as many perspectives in there as possible.
Terrific. Yeah.
A comment and then a question. I think you already answered the question. Obviously this is very political, which is I'm a kind of political guy. It's kind of it's fascinating to watch. I don't know the specific issue that's going down here, but it's either opening or closing of hospital and consolidation of services, and that's all when that happens, it's all very emotional. Communities, their community centers, et cetera. We went through that in Western Maryland. So it's fascinating to watch. I don't envy the task you guys have of trying to choose who's on this committee. With that said, and I think I asked you this before, we talk about rural, and of course I had to get on a horse the last 10 miles going home. I come from a really rural area in Allegheny County, but why didn't we just add Garrett and Allegheny County, and we'd had all the rural counties we could have studied?
So, you know, there was a little bit of a fear of mission creep, that sometimes when you get things that are too big, you don't get any really good focused policy ideas. And I think that the idea that the chairs have had about having this process be a rubric for looking, even if we can't come up with policy ideas that are scalable in other areas, which I think we can, but this process could be a rubric for studying the needs of other regions of the state.
I guess I kind of.
Well, and I also should say
people in our region kind of look at the Eastern Shore as our second cousins, because they experience a lot of the poverty and challenges that the western end of the state experience. So, we sympathize with them. So it just pops in my head again. And maybe the last comment I'll make, and I don't disagree with your assertion some of those folks could have brought some objectivity to what sounds like a pretty volatile process there on the Eastern Shore regarding whatever specific issues those folks are worried about. But thank you.
So I do have to say one more thing, that Mark Bucco, who's the CEO of Garrett Regional Medical Center, is on the group, and he attended the last meeting, and he was great. You know, and Lara Spencer, who is the executive director of the Rural Health Association, she lives out in Garrett County, I believe. So she lives out in Western Maryland.
Yeah, my oversight, thank you.
Lara Wilson, I'm sorry.
I see her on there now.
Actually, what started this whole movement was the risk of converting our hospital to a freestanding medical facility, a fast track, and we got that derailed. And so that's how this whole thing started. They were going to close our hospital.
Yeah, and I don't disagree with what Jerry's implying, but a couple of things. One, this is really loud. Sorry. No, not there. All right, there we go. So a couple of things. One is that I think the broader questions that are looking to be answered is how we deal with the inherent economic inefficiencies of rural communities in Maryland under a global budget, and that question needs to be addressed in a regional fashion, irrespective of how you feel about whether the one hospital, two hospitals, 6 hospitals, whatever, need to be placed in a given area. The bigger question needs to be addressed first. How do we handle the rurality of certain parts of the state under the way we've established the health system? And that can only be done through this process. I would also say that the people that are being chosen as new members, which I believe is what we're attempting to vote on, are also good people. I work with many of them. They are objective people who are genuinely trying to answer some of those questions at a local level for their communities, and I think will bring the perspective of a wider geography than is currently on the mix of people. Does it represent 100% of the 2,800 square miles of the 5 counties? Probably not, but it's pretty good.
Thank you, Adam. Other questions and comments on this side? Clearly, the first half always predominates. Whichever tech. All the good questions.
Can I have one more comment, Craig?
Sure.
Actually, 2 comments. One is that we just had a quarterly medical staff meeting. We're joint medical staffs with the Eastern Memorial Hospital. And it was announced that we've had much better margins than expected, made a lot more money than we expected. So that plus our hospital's been in the black for 21 out of the last 23 years. I just had to ask myself, why are we changing this? We're not a for-profit community hospital serving the people, and you want to change this to a much less efficient, costly system. And I know we've asked for data. That's all we asked for. I would hope that there would be some on-site visits to Kent County instead of just looking in books and collecting data and numbers and so forth.
So the January meeting, I'm working with Kay McIntosh, and the January meeting of the work group will take place in Kent County as well as one of those public hearings as required by the legislation.
Perfect.
Thank you. Terrific. Let's call for a vote to approve the new members of the work group. All in favor? Aye. Aye. Any opposed? Any abstentions? 1 abstention. Noted.
I oppose.
And 1 opposed. Noted. Okay.
Thank you very much.
Members are approved. This is clearly a topic that there's interest in. So agenda item number 8. Ben, do you have an overview of upcoming initiatives?
So, yes, we definitely expect a packed October meeting. We have a number of CON issues. We'll also have a civil report. We'll have action on the state EHR incentive program. That's one that's been in place for several years. We'll be bringing back for final consideration the state health plan for freestanding medical facility, and we'll also seek approval for the home health quality measures that were briefly presented during the update today.
Thank you, Ben. If there's no further business for the commission, I'll entertain a motion to adjourn. Second? All in favor? Aye. Meeting adjourned.